All right, hey everyone. My name is Dr. Brady Wyrick. I'm the Director of Regenerative and Integrative Medicine for Sensormedica Clinics, and this is my presentation about the fourth generation of regenerative medicine that I wanted to share with you. So, first off, a little introduction of myself. This is my family. We live in southeast Idaho, specifically in Idaho Falls. It's a lovely riverside community with tons of outdoor things to do here. We are a blended family, and yes, those are 8 humans in that picture. My wife and I stay very busy. We love being outside. We love spending time together and having a good time. So in the summertime, you'll find us on rivers, you can find us on mountains, you can find us hiking, fishing, biking, etc. I grew up in Ogden, Utah, but it was the outdoor activities, specifically fishing, that brought me here to Idaho Falls when I started my practice in 2006. Holy moly, we're coming up on 14 years. So, yes, I am a chiropractor by training. I've spent my entire career in functional neurology, functional medicine, and then the last 3 or 4 years back in regenerative medicine. So I am excited to share with you what we've learned over that time, and hopefully some clinical pearls for you that you can put immediately into practice for yourself or for your own practice if you are in practice. So this presentation came about because here a couple of weeks ago, I went over to a presentation that was put on by a stem cell exosome company. Every time I go to a seminar or try to learn more, I always get these little clinical tidbits that I try to bring home and try to implement. And that's I've learned a great deal by doing that. So this particular dinner presentation was going to be put on in Boise, and Boise is about 4.5 hours away from where I live. But I felt like it would be worth the drive for me to go over there just to learn some new clinical pearls. And despite what I'm about to say, it was absolutely worth it for me to attend. I did get a lot out of it. I got a free meal that I had to drive 4 hours for. But it was worth it for me to haul over there just to grab some clinical pearls. So I go into this room, and it's at a very popular, very noisy, busy restaurant in Boise. And they have there's probably 10 people that they put into this private room. And I was under the assumption that the speaker was actually going to be there live in person. He was not. And they tried to do it over Zoom, and they projected it onto a big screen TV, and they tried to get the audio over. It looked like some very cheap plug-in speakers on a laptop. And the result was actually kind of disastrous. It was very hard to hear. I sat in the front row, so I was able to hear. But of all the other doctors and practitioners that were there, I could see people getting very frustrated about not only what was taught, but the environment itself. So the problem was that we had our technical AV issues, but what we also experienced, what I saw, was a disconnect between the doctors that are in the lab or on the lab bench that are doing the research that is vitally important in this work. There was a disconnect between them and the actual practitioners themselves. I could see the doctors, and I could hear the comments they were making that were basically, we get what you're saying, but how do we put this into practice? Or in other words, what they were hearing was Charlie Brown's teacher, right? So the doctor, the lab bench doctor is up there giving this awesome information, this very important information about the little minute details of regenerative medicine. But unfortunately, I think that was taken as, by the clinical doctors that were there, as wah, 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 just like Charlie Brown's teacher. So on the way home, I'm thinking about the information that I gained, thinking about my notes, and I'm like, what I want to do is make a presentation or a video about how do we take that wah, which is vitally important, and plug it into clinical practice. That's what this presentation, this video is all about. So if you're a doctor, great, this is written for you. If you're someone who's looking into regenerative medicine, awesome, stick around, because I try to boil it down to share how it's applicable at a very understandable English, a very understandable language that's actually in English. So that's what I'm going to share. So here is an example of what I am talking about. So this is the lab bench versus the clinical practice, right? So here are 3 screenshots of the benefits and features, if you will, of this particular product that we were talking about. We were talking about stem cell exosomes, which we will discuss in this video. But here's all the growth factors and cytokines and other stuff that's in these exosome injections and the important things that they can do for a patient, right? So look, if you just look through this, for example, interleukin-1 beta, right? Cell proliferation, differentiate, modulates inflammation. That sounds like something that's very important. It needs to be discussed, right? So the lab, the bench lab doctor is going through this pieces of information like this while the practitioner is sitting there going, yeah, this is great, but how does this apply to clinical practice? So I want to bridge that gap. This is what this is all about. So a couple key words I need you to understand as we jump into this. Number one, there's 4 key words here. Paracrine action is a key term that you need to understand. Paracrine action is this. All cells communicate with other cells by secreting these chemicals. And these chemicals will transfer via little transportation packets or cars or vehicles or whatever the crap you want to call them. They will go from one cell to the other so that cell A can tell cell B what it wants to do through this paracrine action. That's all that means. So when we get into exosomes, all cells have exosomes. All use them for this paracrine action to talk to and communicate with other cells. That's it. That is what paracrine action means. Then we have extracellular vesicles. This is the actual packet that's released by the cell to communicate with the other cell. So it's the packet itself, the vehicle, the car, the airplane, whatever you want to call it, that goes from cell A to cell B. That is the extracellular vesicle. So if you understand that key principle, the rest of this is going to make really good sense to you. So those are the 2 words, okay? So here's where we're at right now with the FDA. Regenerative medicine as a whole is not FDA approved. They're in this, there's a couple of pathways of getting approval, right? So right now, most of this stuff is in what's called a 361, which basically means, yeah, it's a biologic. Yeah, FDA, the FDA thinks it's safe, and as long as you follow these steps, you can use it. We just can't promise you anything. We don't have any clinical, what's the word I'm looking for? We can't give you any clinical indications. But once enough studies are done, once these companies obtain this IND or investigational new drug, and they bring us enough studies, then we can move it over to this 351. That's a mistake on my presentation that I need to fix. That should say 351. That way they can classify it as a drug and say, here's your clinical indications. We are not there yet. The FDA is working on it. They're making sure that what people are doing is safe, and the indications that they're saying aren't bogus. It is being worked on. There are a few products on the market that are covered by Medicare, for example, through a couple different pathways, but the deal is this: those products are about 15 years behind. So that's the best way to think about it. Over the last couple years, we've been given this deadline of November of 2020. Right now, the recording of this video, it is October 27th of 2020. We were told November 2020 is going to be the cutoff date for the FDA when they're finally going to crack down on there are some labs out there that are doing some unscrupulous things. Those are all going to go by the wayside. So if you're working with a practitioner, if you're working to find a company that is on the good side of the fence, you want to do that because, November 2020 has been pushed into 21 because of the whole COVID thing, which, by the way, I'm just going to throw this out there right now. There are studies coming out of New Jersey for acute COVID patients doing IV therapy and doing really, really well with stem cell exosomes. I will plug that in there right now, but that's where the FDA kind of stands on this whole thing. So when a practitioner goes to a talk like this one or a talk put on by somebody else and they start hearing 361, 351, IND, all these terms are very confusing to people. This is just what they mean. So there's that. Now, there are three main goals of regenerative medicine that we want to discuss. This picture, my very first regenerative medicine patient, and keep in mind I am a chiropractor, so I'm not the one that's putting needles in people. You can't do that in Idaho. We have a medical staff that does this for us, but that picture is our very first regenerative medicine patient. And if you think that man looks like me, there's a reason for that. That is my father. We injected him 2018, so about we're coming up on 3 years of his injection. Bilateral bone-on-bone knees, one injection. And at the time, we were using umbilical cord cells that came from blood, which they're what we found out is they're hematopoietic cells, which mean they produce blood vessels. But lo and behold, here we are today. Dad still has not had to have a replacement therapy. Still doing very, very well on those knees, and I can still outfish him, just for the record. So here's the three main goals of regenerative medicine. Number one, you want to decrease inflammation. You cannot regenerate a joint in the presence of inflammation. You got to take care of it first. But you have to keep in mind that inflammation, in the case of regenerative medicine, is a good thing because it does have that paracrine effect that will signal the stem cells to come to the site of injury and repair that mechanism. We'll talk a little bit more about that later, but you cannot regenerate an inflamed joint. Number two is you do want to modulate the immune system. You want to control the reaction that's happening at the joint level, so it gives it its best chance to heal. And number three is you do want to regenerate and regrow new cartilage in the joint. That is the ultimate goal. And what we now know is that these stem cells have a chemical signal that goes to the cells in the joint called chondrocytes that produce new cartilage. And number four, I said three main goals, I meant four, is to improve your overall health status. You want to take someone like my dad and get him back on his bike, get him hiking, get him active again. Judging by the Pepsi that's in the cup holder of my friend Ed's boat, he's not taking all of the precaution, all of the steps he needs to take to be well, but he is more active now than he was before we did the injections, and that to me is a solid W, as my 14-year-old stepson would say, as in it's a solid win. So let's go through the generations of regenerative products. So 1970s, concentrating growth, or PRP. I sarcastically put in here, concentrating growth factors and cytokines since the 1970s, which is absolutely true. Starting in the 70s, we started spinning blood down in a centrifuge and taking that plasma. When the red blood cells sink to the bottom, that plasma is left up there on top, and we can inject that into joints and have a pretty profound effect on the joint itself. And what PRP does is basically, number one, it's anti-inflammatory. That plasma is full of growth factors and cytokines to knock the inflammation down. They are responsible for angiogenesis, which means it will help blood supply to grow. It does help those cells to proliferate, and it stimulates chemotaxis, or that paracrine action. Those, one cell telling the other cells what to do. It can stimulate your own stem cell response, which helps differentiate cells. And then it begins to build what we call the collagen fibrin scaffolding matrix. But if you think about a building that's being built, they put scaffolding on the outside and then build the building on the inside. This is a lot the same that happens with that particular matrix. And very, very, very good at short-term pain relief. Even though PRP is the first generation, it's been around the longest, there are literally volumes of books, of studies that are written about it, and it is... we use it to this day with every single injection that we do. So we love PRP. It gives the patients that short-term pain relief, while the exosome injections can help with the more long-term stuff. And I compare it a lot to ether starting fluid. If you've ever had an old worn-down engine that you've tried to start in the cold and it just doesn't want to start, you spray that ether starting fluid into the carburetor or into the air intake, and lo and behold, the engine will usually kick and fire just to get things started. And that's kind of what PRP is in the regenerative process. It's like that ether starting fluid being blown into the joint, for a really, really bad analogy. But that's what it is. Hey, Roll forward to the second generation of biologics, that is the autologous stem cells. This is taking stem cells from your own fat tissue or your own bone marrow. So this started around 2007, where we're taking it from adipose or bone. It does help with cartilage growth. It can help stimulate those cells to produce more cartilage. It has been shown to be a long-term change. There are papers out there suggesting 5 to 7 years of long-term change. It is, however, age dependent, and I will tell patients the more gray hair you have, the less likely you have that it's going to do something. And we do see long-term improvement, so that's in there double. I'll take that out. So that's the second generation, and what I will tell people: yes, this is a viable option. Yes, there are other practitioners in my area that will do this for you. If you're more comfortable doing it that way, then by all means, please go do that. Just knowing that I do feel like it is going to be less effective and it is more expensive, and there's recovery time involved with that because it is much more invasive than what we're talking about. Fast forward to the third generation of biologics. Now we're talking about umbilical cord stem cells. 2013, no pun intended, but the birth of an industry, which was both good and bad. My opinion is this is the best discovery that we've had in medicine since penicillin. The bad is that there's plenty of people trying to make a profit that have jumped on this bandwagon, and now we have these hundreds of companies all claiming that their product is the best and all kind of going to war against each other. And frankly, I'm looking forward to the FDA cracking down and getting rid of some of the BS so that we can truly proceed and progress as an industry. It is 2020, and I am still answering questions about embryonic tissue and aborted fetal tissue. I'm sick of this question. It never was about this. The people that get all fired up about it are frankly uninformed, and it is your job to tell them, no, this is not embryonic cells. This is not aborted fetal tissue cells. Those cells are dangerous. They can stimulate tumor growth, and they're frankly just immoral and wrong. What we are talking about is donated tissue from healthy moms, healthy births, from cesarean sections. Nobody was harmed in this, right? Anyway, I've beat that horse. It is a cellular product, so you are getting stem cells, whether from the cord blood or the amniotic fluid or the cord matrix itself. So you are getting stem cells. There is minimal risk of rejection reaction. These products were packed in DMSO, so we did see people with sulfa allergies getting a little yucky from it. But the rejection reaction is typically when you inject a joint with this stuff, the rejection reaction isn't like you're trying to reject an organ. It's more along the lines of, hey, it just didn't work. It's typical what we saw with the injections that we've done. It is non-age dependent, which is really cool. We've taken patients in their 90s and injected them with this product, and I've seen result from it. It does have long-term effects. I will tell my patients this all the time. There are papers suggesting 5 to 10 years from this country, out to 15 from other countries, but I never look someone in the eye and tell them this is how long it's going to last. You just can't do that because it is called practicing, and you just don't know how individual patients are going to react. The less medication you're on, the better chance that you have, but you just want to make sure you manage their expectation. What we used to think in this process was that those stem cells, remember the 4 things that they do. Number 1, they are anti-inflammatory. Number 2, they do help modulate and control the immune system. But we used to think that the cells themselves actually became the tissue that you were trying to affect. So you could take this mesenchymal stem cell, put it into a knee joint, and that cell would actually regrow, would become cartilage in that cell or in that joint. We now know that that's not true. So that bumps us now into the 4th generation of biologics, or extracellular vesicles, also known as stem cell exosomes. These are the chemical messengers that are secreted by the stem cells. So we're not using the cell itself anymore. We're talking specifically about the extracellular vesicles that they release. Those are signaling agents to the joint. The joint itself produces the cartilage. It doesn't turn the cell into cartilage. So when we made that switch, we basically went increased our success rates because we're increasing the potency of the therapy, but we're also increasing the safety issues. There's no longer a DMSO issue. These are much safer. They're much smaller vesicles than what the cells were. There's no DNA whatsoever. And we will find in that 2020, now 2021 issue that I think you're going to see cellular therapy actually go away, and we're going to rely on things like stem cell exosomes. So what is an exosome? I said before, all cells release exosomes. Every single type of cell has exosomes, has these little chemical packets that you see up here in the upper right part of your screen. These are the exosomes. They have a phospholipid bilayer just like the cell itself. So it's almost like the cell envelops in on itself, creates this exosome, and then allows that exosome to leave containing those acellular products that are the chemical communicators. So these chemical communicators include mRNA, messenger RNA, microRNA, growth factors, and cytokines. If you go back to the first of the presentation, when I had those 3 screenshots, that's some of the growth factors and cytokines that they're going to contain. So those cells, those stem cells, release those exosomes. Those exosomes go to the actual site of the injury, and they will tell your cells what to do. And in the case of, I said they're already non-cellular, they're the size 1/1000th of a cell. But in the case of messenger RNA, for example, one single messenger RNA has the ability to produce thousands of proteins. To tell your cells to produce thousands of proteins. That's just one single mRNA. Well, we're talking about hundreds of thousands, possibly even millions of exosomes, and each exosome containing thousands of its own mRNA, and you start doing the math, the exponential math on that, the potential for protein growth here is, like I said, it's exponential. So as far as like a clinical application, this is what we're seeing, the most effective, how we're seeing the most effective results, and this is exactly how we're doing it in my clinic. Okay, so an osteoarthritic knee, someone who's otherwise generally healthy. Okay, so I'll go through their medication list, and if they're taking a ton of medications, I will try to talk them into not doing this, because there's always, the more medications you have, the more chance you have of something going goofy on us. But for someone who's on, say, 5 or less medications, 1 cc of these exosomes per joint, plus the PRP is injected directly into the joint capsule. And the cool part about this is these procedures are so powerful that guided imaging looks good to the patient. We do it on occasion. It's a nice sales point, but it's not really necessary. A skilled practitioner can go into the joint capsule of a knee. Okay, and you inject this product, so cc of exosomes, and let's just say we get 4 cc's of PRP out of the patient. You inject that into the joint capsule. It's that simple. I know a lot of practitioners, when they hear about this, they want to know some really juicy detail about it, and they want to overthink it, but no, it's really that simple. A shoulder, 1 cc joint of exosomes is injected with PRP, just like we do with the knee. Those 2 joints respond the best. The next on the line is the spine. We're getting great results with the spine, and here's exactly how we do it. We'll do 1 cc of exosomes per level plus their PRP, but keep in mind, the bigger the patient, the more you're going to have to use. Okay, so we inject it into the paraspinals bilaterally at the site of the injury. The magic word when you're looking at imaging is facet arthropathy. We're very upfront with people about the radicular symptoms. If it's going down past their leg, then, or going down more into the arm, then we will tell them there's a chance that may not go away. But then I explain to them how facet arthritis causes the stuff that goes down to your knee, and because of geography, those facet joints respond really, really well. If you have the ability to do imaging in this case, then do guided injections, by all means do it. I'm just telling you that going into the muscle, into the paraspinal muscles, we've had great success doing it that way. So if I have someone that has multi-levels, I'll use 2 or even 3 cc's, and then we'll inject several different areas when we do that. We could do 6 or 8, 3 on one side, 3 on the other, 4, but that's a patient-to-patient basis. The hip is a little bit trickier. If you have the ability to do guided imaging into the actual capsule, do it. We've done mostly doing through the SI, doing an SI injection or into the lateral aspect of the trochanter. And we've done that well that way. They don't respond quite as well as a knee or a shoulder, but you will end up using a little bit more of the exosomes with doing hips, especially as the patient size increases. And that's also with PRP, so I didn't add that in there. Now, that's for the osteoarthritis of those particular joints. Yes, you can do smaller joints. Yes, you can do the TMJ, joints in the hand, etc. But for everything else, for overall general health, we will do an IV. We don't do any of the intranasal stuff. It's just, everything else is just via IV. And the tricky part about IVs is you have to use a lot. You can't really get away with doing one or two unless the patient's pretty healthy and small. But you're going to do best with a 5 cc IV. The problem with that is it becomes a financial tolerance issue, right? Because a 5 cc vial is not cheap by any means. So there is a financial tolerance issue that is there, but you have to be very, very forward with the patient because they are putting their own money on the table because insurance doesn't pay for this. So you really can't get away with, and you shouldn't get away with promising them the moon. I had someone earlier ask me a question about schizophrenia, for example. Can stem cell help schizophrenia? My answer was, yeah, but it's always that unknown factor once you put those into the bloodstream. So with IVs and with everything else, we're not treating anything specifically. They're signing papers saying I am doing this for my overall general health, etc. So clinically, that's how we do it. The clinical mechanism, excuse me, the clinical mechanism for exosome therapy is this. Number one, inflammation acts as a paracrine signal. It is vitally important to have patients off of anti-inflammatories 3 days prior to an injection. Hands down, that's the most important thing that you can do before we do the injection. The more inflamed they are, the better they will react. And hopefully, after the injection, they never have to go back to their anti-inflammatories, which we've seen a lot. But PRP is injected with the exosome, acting as a short-term anti-inflammatory. You will see 5% of cases or more get off the table feeling better, and scaffolding will begin to form in that first week or so. But it is important, chondroitin, glucosamine, protein, healthy proteins, healthy fats, and hydration are key parts of that. As I said before, the matrix scaffolding begins to form. Exosomes will signal chondrocytes to form new cartilage in as little as a week, with the biggest changes seen in 6 to 8 weeks. So I will tell patients when they do this injection, look, there is a chance we could get results within a week, but expect 6 to 8. That way they're just managing their expectations. And the ultimate outcome is hopefully that the surgery, any surgical intervention is either delayed or avoided altogether, which we're seeing more and more of. And then another thing I make sure I point out to patients is your imaging is not going to change. Hey, even with the exponential protein growth capability of what we're doing an injection and then doing an MRI, a year later, you're not going to see much difference if you see any at all. The MRI, the imaging that's needed for actual measurement of the cartilage in a joint, they're very expensive, and it's usually big university hospital systems can afford the particular type of MRI. And the name of it is escaping me, but we just don't see that in Southeast Idaho. So I will tell people, yeah, we could do an imaging later down the road, but you're just not going to see much difference. So make sure you point that out. So follow-up care, you do have options. I know in my office we do low-level laser therapy and we do shockwave therapy as an adjunct, as follow-up, because those two things in combination can help stem cell proliferation. But we also use custom orthotics in my office because I'm a big believer in biomechanical chain. If their gait is off, it's going to affect everything else. So we want to make sure that's addressed as well. But that's how we do it. So, hey, I hope this has been helpful to you. I've tried to just kind of lay it all out there for you. If you've got questions for me, please feel free to reach out, and we will be happy to answer whatever questions you have. Thank you again, and we'll see you on the next video.